Hi, my name is Jeff Hodrick. I'm an orthopedic surgeon who specializes in joint replacement at Southern Joint Replacement Institute. I'd like to spend a little bit of time today talking specifically about the treatment of knee arthritis, both non-surgical treatments as well as knee replacement. And then towards the end of the procedure, we're going to spend a little bit of time talking about something I'm pretty passionate about, and that's robotic total knee replacement. Just by way of introduction, I've been here in Nashville for about 10 years. Went to undergraduate at Duke University and then medical school in Pennsylvania at Penn State University. Did my orthopedic training at Duke University in Durham, North Carolina, and then chose to do an additional year of adult reconstruction work and a fellowship under Dr. Aaron Hoffman at the University of Utah. So we're going to spend a little bit of time and I'm going to show a little bit of slides and talk about osteoarthritis. By way of disclosure, I do some education work with one of the orthopedic companies called Stryker, who does represent and provide the robot. It's something I'm passionate about, I believe in. I also believe a lot in education. We teach fellows here at Southern Joint Replacement Institute. I think it's a way for us to hone our craft and also stay sharp and abreast of the latest technology and techniques. Basically, I'm going to talk about what knee arthritis is, hopefully simplify that for everyone to understand, and then probably what everybody wants to hear is, how do I know if I have arthritis? And if I have arthritis, what should I do about it? When should I go see the doctor? And then towards the end, perhaps we can even talk about some frequently asked questions which may be helpful in treating the knee arthritis that you have. As far as the knee, really it's quite simple. The knee joint itself is where your femur bone or thigh bone joins together with your tibia bone or shin bone. Now, because it's a joint and it moves, it has cartilage on the end of the bone. And the cartilage really is that shiny white stuff that you might see on the end of a chicken bone. Now, over time, that cartilage can become damaged. This might be just generalized osteoarthritis, where it generally wears away, and that's a mechanical wearing away of that cartilage. Underneath the cartilage is bone, and that bone has nerve fibers. So if you get to be bone against bone, which is the knee osteoarthritis, that's what would cause the pain, stiffness, and swelling that you can experience with that. Around the knee, there are some other tissues. Of course, there's ligaments that join bone to bone, as well as the tendons that join the muscle to the bone, including your kneecap, which is on the front of your knee. This is just, I think, a pretty good description of really what osteoarthritis is, and I think it's easy to think about a car and think about a tire. So if you think about a tire, if you have wear and tear on that tire, unfortunately that rubber never goes back on the tire. If your tire is worn out and if you take it to the shop, they're not going to try to glue rubber back on that tire. The same is with arthritis. It's a continually degenerative condition, so it continues to wear away off the end of the bone just like a tire does. Now, if your tires are out of alignment, just like your knee, so if you're bow-legged or knock-kneed, you're more likely to get osteoarthritis on one side of your knee or the other because there's additional forces to that knee. It's very common. Arthritis means anything with itis is bad. So when you hear tendonitis or arthritis, it means swelling or inflammation, and arthro means joint. How do you know if you have it? So typically it's pain, and it can be a stabbing pain. Sometimes it's a dull pain. Sometimes your joints are warm to the touch. Oftentimes you feel like you have swelling inside your knee. People describe this as water on the knee, and that's pretty common. That can also cause a stiffness. So if you bend your knee and as you bend it, it gets stiffer and stiffer or tighter and tighter, that's usually water on the knee, and that's pretty common. Unfortunately, if you do have pain and stiffness, this can lead to some other things, and that's typically when we see you in the office. So if you're not able to do the things that you want to do, you're not as mobile, you're not able to go up and down stairs or have pain when you go up and down stairs, that's when you typically go and see an orthopedic surgeon. This is just a kind of a depiction of what the x-rays look like when you come to our clinic. On the left would be the healthy knee. So again, the thigh bone's on top, the shin bone's down below. The space in between those two bones is cartilage. If you look on the right, you can see the difference. So on the inside part or on the left side of that x-ray, you can see those two bones, there's no space in between. So that would be bone against bone because that cartilage has worn away between those two bones. And that's what osteoarthritis is. Again, here's another depiction, more in a cartoon fashion. On the left would be a healthy knee. Again, the shiny white stuff that you see, that would be a healthy knee. On the right, you see that red area, that would be the area of arthritis, where the cartilage has worn away and exposed that underlying bone. So what can you do? Well, we always like to encourage someone to be more active and can certainly benefit from being stronger and even losing weight. So It just stands to reason. If there's more weight on the truck, there's going to be more wear on the tire. So if you can take some of that weight off, your knees or hips will feel better because of that. We also know that doing some exercises and getting better shape before a knee replacement surgery can ensure a better success rate after that surgery. This is something that's kind of interesting, and one of the reasons why I've become interested in robotic knee surgery. So if you look at the trend of knee replacements in the United States, and this is a study that's often quoted at our national meetings, this is a projection and a curve, and you see it goes out to 2030. So this would be the number of knee replacements that will be needed in the United States. And this is kind of the collision of the baby boomer generation and ongoing increasing population in the United States, and also the increasing demand, patients coming to the doctor a little bit earlier and probably being a little bit harder on their body and requiring knee replacement sooner. So you can see a 673% increase by 20 and 30. That's quite large. Now, with that, we want to make sure those knee replacements last a long time. So that's a common question. How long will my knee replacement last? The statistics show about 15 to 20 years for about 85 to 90% of knee replacements, which is really good. That's a good number, and that's a good result. So my hope, and when I talk to my patients, if we can give you, or I can give you, a knee replacement that lasts 20 years, and if you wear out the plastic piece in between, and that's the reason why it fails, that's an excellent result. Okay, number one, we can put a new plastic piece in, but number two, and probably most importantly, it means in that 15 to 20 years, you've been extremely active, so active that you've worn out that plastic piece. This curve shows the number of revision knee surgeries, which becomes much more complex and something we want to avoid. So my charge in what I do, I want to do the best job possible the first time around to make sure that knee replacement can last 15, 20, or 25 years. What are some other things we can do? We talked already about physical therapy. So if we can get you in better shape, get the muscles stronger around your knee, it can take some pressure off your knee and knee osteoarthritis. Now, our job is to make sure you're as active as you possibly want to be. So if you're not and you're still having pain, then we probably need to move to the next level of care. Now, some things you can do, you can take non-steroidal anti-inflammatories. What are those? Those are things like Aleve or Advil or ibuprofen. Or you might be on a prescription drug like meloxicam or Celebrex. What these do are basically treat the body's inflammation through a pill. It kind of goes in your body. Now, unfortunately, this pill goes in your mouth, goes to your stomach, goes to your intestine, goes to your blood, swims around, and then treats your knee. There's another way to do this. We can actually instead inject steroids right into your knee. And this is a common treatment that we use in the office. So by doing that, you don't have the systemic effects. We don't have to worry about your stomach, which, some of those pills can bother your stomach, but we're delivering a potent anti-inflammatory directly to the site of inflammation, which is inside your knee. So people ask, this is another common question, well, when do I know? If I have osteoarthritis, I've been to my doctor, I've had my x-rays, and they told me I have bone against bone. When should I consider having a joint replacement? I typically tell patients to think about 3 things or 3 check boxes. So if you have to think about your knee every day, that's one. Okay, because that's definitely on your mind and it's affecting your day-to-day activities. The second thing is, does it keep you from doing things that you want to do, or you used to do, or you need to do? Sometimes that's work. Oftentimes it's family activities, it's recreation, it's getting on the ground with new grandchildren. These are very important things, and certainly very important to quality of life. And then the final thing is, does it affect your quality of sleep? That doesn't necessarily mean that it wakes you up in the middle of the night and you point your knee and say, ow, but perhaps you have to sleep in a certain position, or maybe every time you roll over during sleep, your knee hurts. And if that's the case, and you can say yes to probably 2 of the 3 of these questions, I think it's reasonable to consider a knee replacement at that time, because it's really a quality of life decision. What do we know about knee replacement? Well, here's the good news. Knee replacement's a great operation. It's been around for a long time. It's got an excellent track record for getting rid of your pain. If we can do the proper rehabilitation after the surgery and pair strong muscles with a good result from the surgery, then a patient can get their life back. If we can get rid of the pain, you increase your strength and you increase your function. We know that it works. It's one of the most successful medical interventions of all time, right up there with cataract surgery and open heart surgery. What are the other options? So, okay, well, what if you are a little bit bow-legged? And like I said, just like tires on a car, if you only worn out the inside part of your knee, okay, the rest of your cartilage in your knee is normal, then you might be a candidate for a partial knee replacement. The advantages of the partial knee replacement are, number one, it's not as much surgery, so it tends to be less pain, less blood loss, less recovery. You're also keeping the main two ligaments in the middle of your knee. This is the ACL and the PCL. If you're able to keep those, your knee typically feels more like your own knee, and you're a little bit more able probably to do lateral type activities and seem to be a little bit more efficient at doing things like stair climbing. Now, not everybody's a candidate. Now, if we did a partial knee on someone that had arthritis in other parts of your knee, it just wouldn't be successful. So that's something that you have to speak to your surgeon about. Now, as the arthritis progresses through the other parts of the knee, there are other options. So of course we could do a complete knee replacement where we replace all the cartilage with metal and then have that plastic piece in between. So here's an example of what a partial knee replacement looks like on the left. I think you can see that metal surface. There's a metal surface on top, which basically is a cap or resurfacing at the end of the thigh bone, and then a metal cap below with a small white plastic piece in between. On the right, I think you can see the difference also. It looks like a metal shield. So there's metal on top and then metal down below and then plastic in between. People ask a lot of times, what are these things made of? This is probably a good time to talk about that. Most commonly, the metal piece on top is made of something called cobalt chrome, which is a very durable, it's a metal that does very well inside your body. It's very wear resistant. The metal on the bottom part most often is made of titanium, which is another metal that's often used inside the body and the body responds to very well. The plastic piece in between is made of something called polyethylene, which is like a Teflon, a very wear resistant plastic. The biggest advancement, I think, probably in materials at least, in the last 20 years happened about 19 to 20 years ago. And that was an improvement in that plastic that makes it extremely wear resistant at this time. And that's the reason why these knee replacements may last 20, 25, or even 30 years. Okay, here's an x-ray example. On the left is basically a lateral or a picture of the x-ray from the side. On the right is the preoperative state. Now what we're looking at again is the thigh bone and the shin bone, and then no space in between. The edges of the bone that you see both on the front and the back are bone spurs. You know, bone spurs are your body's reaction to osteoarthritis. It thinks it's doing you a favor by putting down this extra bone, but it's not. It's more a symptom of the disease. A common question we get, well, why can't you just go in there and take out bone spurs? If you take out those bone spurs, it's the inflammation that's the problem. You have to shut down the generator. So if you just take out the bone spurs, they'll come right back. Also on that picture, out in front of that knee is your kneecap. I think on the left side you can see there's a metal cap that fits right on the end of the bone. I think replacement sometimes is a little bit of an intense word. This is more of a capping on the end of the bone. So you kind of see that metal piece on the end of the bone, a metal piece on the top of the shin bone. You can't see the plastic, but perhaps you can see the shadow of the plastic that lives in between. This is that same patient, but now from the front on the right. Again, if you look at the knee that's on the left, this would be an example of someone that is a little bit bow-legged. They put more pressure on the inside part of your knee. On the left, again, you see everything that's white there is metal, and then there's a piece of plastic that sits in between. And I think you can appreciate just by looking at that, although it's a small x-ray, that we've been able to straighten the leg. Okay, let's shift gears a little bit and talk about robotic knee replacement and why I use it. I really feel that robotics has a place in orthopedics. It makes sense. It does a couple things for me. Number one, I think it makes me a better surgeon, which I think allows me to do a better procedure, which I hope will translate into a shorter recovery, a better recovery, and then a longer, excellent outcome for my patients, and that's why I believe in it. So what do we do? So typically, when we do knee replacement, we do some planning on the front end. If we use an x-ray to do that planning, we can only do it really in 2 dimensions. Before a robotic knee replacement, patients get a CT scan, and this is an example of what those CT scans look like at the bottom of this screen. That gives me 3-dimensional information. So instead of just looking at a knee from the front or a knee from the side, we can also look at the knee straight ahead. And that's very important when you bend your knee, because it does matter where you put that component rotationally on the end of the femur. Okay, you can kind of see that would not be necessarily balanced or even, that would be. So it's important where we place that femur. We can do that during the procedure and actually adjust it during the procedure before we make any bony cuts. Now, this is kind of that planning stage. So if you look at the screen on the right, you can kind of see the green cartoon image. That is actually your knee. So this is a custom knee replacement because it fits directly to your knee. We can adjust, before we cut any bone, the position of those components. It then gives us information, number one, about the position of your knee in space, meaning how straight it is, and then also tells me how much bone we've removed. It becomes a little bit of a math problem because oftentimes we want to put back in metal what we take out in bone. And it kind of makes sense when you're trying to balance a knee like that. So that's that custom 3D model I was talking about. On the left is a CT scan, then you can see on the right of what we can do both on the top with a total knee replacement and then the bottom with a partial knee replacement. So all this is done before the surgery even begins. During the procedure, and this is kind of the marriage, some people think that knee replacement is largely a bony operation. Some people think it's more about the ligaments and the soft tissue. The robotic surgery actually allows you to do both. So we've done a lot of the planning, which really takes into account the measurements and the bony part of the operation. During the procedure, I'll actually move your knee in space, and that tells me again how loose or tight those ligaments are. Based on that information, I can then manipulate those components once again before we make any cuts to make sure that your joint is balanced before we even cut the bone, which I think is very valuable. And then finally, the CT scan also is able to set up what's called a haptic boundary, and we can think of that as almost a force field. So the saw blade on the right that you see, and then also the burr or high-speed burr on the left, has to stay within a boundary. Okay, and this is set up by the computer program. If that saw blade attempts to go out of that boundary, it automatically shuts down, which is number one, a patient safety factor. There are very important things around the knee. There are ligaments we don't want to cut, tendons, as well as, of course, the blood vessels and nerves around your knee. So it's a safety concern as well. But also, this saw blade that we use is twice as thick as a standard saw blade, which allows us to be much more precise. So instead of that saw blade when it is turned on, and it might skive up or down depending on if the bone is hard or soft, it stays directly on plane. So when we're talking about precision, we're talking about tenths of a millimeter rather than 2 or 3 or even 4 millimeters of error that could occur. Another common question, well, am I sitting here in this room while a robotic surgery is happening in our operating room? No, not yet. In 20, 25, 30 years, that might be the case. The way it is programmed, it is a robotic arm that I control. So of course I have control over the trigger. I also of course have control over that preoperative plan and then the adjustments that we made during the surgery. Recovery, what's realistic? Again, this is a big surgery, but I can tell you that if we can do a better job during the operation, especially handling the soft tissues, and also producing a balanced knee. And a balanced knee, again, if those ligaments are the same length when your knee is straight as well as when your knee is bent, then it's easier to recover and it's easier to get your range of motion or your bend after surgery. So there tends to be less inflammation and hopefully you'll have a pain-free knee. Our goal when we do knee replacement is, usually after a year, is to give you a forgotten knee. Basically what that means is you don't even have to think about it until you come back for your appointment and get an x-ray. So if you can live your life and not have to think about your knee replacement, that means that we've been successful. And that's what I hope for all my patients. This is just a little bit of plug. We're very fortunate in this building to have a brand new state-of-the-art, I think probably the best in the country, joint replacement center with 10 operating rooms. They're brand new and they're dedicated only to the care of joint replacement patients. Why does that matter? All our staff do joint replacements every day, and that's all we do. So the anesthesiologists you're dealing with, the nurses you're dealing with, the front office staff, all dealing with. And there's a lot of conveniences and amenities, both for the patient as well as the patient family, which I think makes it a much more relaxing and a great atmosphere to recover. Now, some of the frequently asked questions, what are the chances of me rejecting my knee? Extremely rare, and it might be 1%. So when folks have an allergy to metal, it's typically females, and it may be a nickel allergy. And usually when they come to clinic, they say, well, whenever I wear cheap jewelry, and my wife typically says that because it needs to be 18 karat gold or diamonds, but if they wear cheap jewelry, they might get a skin reaction. Even at that point, it's extremely rare. rare that you would have this. Now, there are some tests that we can do before surgery, but a true metal allergy that would affect the surgery is extremely rare. Now, if you've had some of these skin reactions, this is still something that you can tell your orthopedic surgeon. The next question is, what can I expect for recovery, return to work? Questions like that. You have to do physical therapy for 6 weeks. Everyone's recovery is a little bit different. I've had patients that go back 2 weeks after surgery, 4 weeks after surgery. Sometimes it takes 2 or 3 months. A lot of it depends on how active and how strong you are before surgery, and that's why sometimes we recommend physical therapy. But full recovery is usually about 3 months. You continue to improve the entire first year after surgery. Typically on a walker for a week or two, then you get to a cane, and then usually after about 3 weeks, 4 weeks, you're not using anything by the time we see you 6 weeks after surgery. Driving, usually let patients drive. If it's their left knee and not their pedal leg, then usually as soon as they're off strong painkillers, which is usually a week or two after surgery. I'm a big advocate of not using strong pain medicine after surgery unless we need it. The best thing we can do is control inflammation. So I typically tell patients to try to control the swelling. So use a lot of ice or specialized ice machines we can use after surgery for this, and also try to keep your leg elevated. The less inflammation you have those first 2 weeks, you really take off in your recovery. So that certainly makes a big difference. That's all I have for today, talking about knee replacement, and specifically robotic knee replacement. I can tell you that if you do have knee arthritis, this is a surgery that you can get better from. I would encourage you, if you have not yet, to visit with an orthopedic surgeon, and certainly we'd be happy to see you at SJRI. Thank you.